Welcome back to More Health, Less Healthcare. I'm Peter Boland, and in episode two, we're going to look at finding the money and what local actually means. Now, last time we looked at two hospitals that treated their neighborhoods as patients and got real results, which raises the obvious next question: how do you actually pay for it? Well, I'd like to draw some more examples from the Health Equity Case Studies Handbook. University Hospitals in Cleveland gave me the clearest answer I found anywhere. You pay for it by eliminating the waste that's already sitting in your system. University Hospitals built what they called a zero defects framework across the whole enterprise. 37,000 employee health plan members and 580,000 ACO patients. And initially, they looked at a subset of very, very chronically ill Medicare patients. The idea is straightforward. Define value as quality and experience divided by cost, then systematically eliminate everything that adds cost without adding value, like unnecessary variation in care, low-value services, fragmented handoffs between providers, and avoidable hospitalizations. The financial results are worth sitting with for a minute. Employee plan costs rose only 1% in the years they studied versus 6% the year before, while Medicare costs fell 6%, while the national average rose 6%. Hospital discharges dropped 15%, skilled nursing admissions dropped 31%, post-acute spending fell 32%, and ER visits dropped 13%. And the share of patients discharged straight home instead of to a facility climbed from 66% to 85%. Now, this is just in the first year alone. So by eliminating defects in how care was delivered, university hospitals generated roughly 9% in annual cost reduction. Plenty of money that could fund any number of new initiatives, including upstream community investment, while also improving quality and the patient experience. Not a trade-off, but both at once. This is the point, I don't think we can repeat enough. The money for local health investment is already inside the system, but is currently being spent on unnecessary hospitalization, preventable complications, and fragmented care. Redirect it towards prevention and primary care relationships, and you get better outcomes at lower cost. Not someday, but in year one. And the data conclusively demonstrates this. So let's take a look at what local actually means. And I want to draw a distinction that's easy to blur. There's healthcare that's delivered locally, and there's healthcare that's, accountable locally. And most American healthcare is delivered locally, like the clinic down the street. But accountability, who decides what success looks like? Who controls the resources? Who answers for failure? Often sits somewhere entirely else. Let's take Dubuque, Iowa. They understood the difference. And IBM picked Dubuque for 4,000 new jobs based on the quality of their healthcare. And Dubuque didn't respond by building a new wing or creating more specialist capacity. What they built was a network of primary care, local physicians, nurses, health coaches, focused on prevention and the kind of ongoing relationship that actually makes managing your health possible over time. And communities don't get this measure success by how many hospital beds they have. They measure it by how rarely their residents need one. Let's take an example of Pittsburgh Public Schools. They negotiated teacher coverage at $4,600 per year, compared to $8,800 in nearby Philadelphia, saving close to $200 million a year. By steering employees toward high-value local primary care and educating them on how to use it well. Now let's look at the Rosen Hotels in Florida. It saved over $300 million cumulatively, spending half as much per employee while offering noticeably better care. Again, through on-site health coaches, nutritionists, and nurses. And here's where it gets bigger than just a cost story. Rosen invested those savings, college tuition for full-time employees and their kids, community giving that helped cut crime by 2/3 in nearby Angelo Park, pushed high school graduation to 100%, and got more than 75% of the Angelo Park graduates into college against a national baseline of 4% for similarly disadvantaged communities. What's further proof? Well, Rosen's $13 million in community investment over 25 years is estimated to have returned more than $90 million to the community, and that's real money. That's what it looks like for healthcare to be local. The benefit circulates in the community instead of just the institution. Health improvements feed education improvements, which feed economic improvements, which feed more health improvement. The loop reinforces itself when the money stays home. So as impressive as the Rosen model is, it has limits. At the same time, I have to say there are limits to the employer model in all fairness. I want to look at this one in context because I think it matters. Rosen hotels and Pittsburgh schools work well for the population they cover, employed people with stable jobs and benefits. But what about the communities where there isn't a generous anchor employer, at least not yet? What about Medicaid populations, the unemployed, gig workers, people between jobs? What about maternal mortality, which needs coordinated investment in doulas and housing, transportation, and provider bias training, none of which fits neatly inside an employer benefits package? Employer-driven models, as powerful as they are, can't achieve health equity across an entire community on their own. Equity means reaching everyone in a place, not just the people lucky enough to work for an enlightened employer. That's not a knock on the model. It works for many people. Now we're shifting what will work for everyone. And it's a reminder that the model isn't finished yet. So in closing, we can look at Nationwide Children's, Boston Medical Center, University Hospitals, Dubuque, Pittsburgh, Rosen Hotels, all pointing to the same underlying truth. The future is local because health is local. The question is whether we build accountability structures that match that reality, or we keep spending trillions treating the downstream consequences of conditions we refuse to address at the source. Which brings us to something I think doesn't really get said out loud, and at least not often enough in this industry. Compared to what? And that's next. Next episode, we're going to focus on what do we compare our performance to. So stay tuned. This is going to be a very, very interesting next episode. I'm Peter Boland. Thank you for tuning in to More Health, Less Healthcare.